Good morning and good afternoon. I am pleased to welcome you to a UCSF Health Hub 2021 Winner's Circle webinar with Innovaccer. Today's webinar will be recorded and shared. If you have any questions, please feel free to use the Q&A button at the bottom of your screen on your Zoom navigation menu. My name is Melissa Faulkner. I'm the Executive Marketing Director here at UCSF Health Hub. Our mission at UCSF Health Hub is to help the next best digital health and life sciences companies develop ideas, validate, and scale. We do this in a few ways. We host events and webinars in person and online. We offer a Connect matching program that matches entrepreneurs to an advisor, investor, mentor, and/or clinician. And we host the UCSF Health Hub Digital Health Awards, which seeks to find the next best upcoming, most disruptive and impactful companies in the digital health and life sciences spaces. This year, we feature 11 different categories. You can learn more about our 2022 award show by scanning the QR code on your screen. The submission period opens on May 3rd. The reason we are here today is our 2021 Patient Cost Savings Award winner, Innovaccer. At this time, I would like to introduce you to our session moderator, Dr. Daniel Kraft.
Great, thanks so much. It's a real honor and pleasure to be here today. I've been lucky to be involved with UCS Health Hub since its inception and to be a judge for the last couple of years of the Health Awards. And it's exciting to see digital health, accelerate in this era, and a lot of amazing companies and energy in the space. And we're meeting some of them here today, including Innovaccer, one of the winners from 2021. And just as a bit of framing onto the next slide, I think part of the theme of this webinar is that we're really moving from this digital area of digital realm of healthcare, whether it's digital health, mobile health, connected health, whatever we want to call it, is bringing us new forms of data sets, exponential data from our wearables and our genomics and our electronic medical records and our billing. And the challenge for all of us as clinicians, as patients, as innovators, is to kind of go from this big data and to turn that into actionable information that might not just be published, but then turns into insights that we can use at the patient's bedside or website. And I think a bit of the theme today is how do we cross-collaborate, whether it's the issues of interoperability or cross-collaboration or aligning incentives and workflows to really move from data to insights to knowledge that's useful and really moves the needle across the care continuum. So that's a little bit of framing. And now I'm fortunate to introduce our four lead panelists. We have Abhinav Sashank, who's the co-founder and CEO of Innovaccer. Each of them will share a bit about what they're doing and their key vision. Next, we also have Ashok Chanuru, who's the Chief Data Analytics Officer at Anthem, Sanjay Dodamani, co-founder and CEO of Upstream Healthcare, and Sukhveer Singh, Global Head of Healthcare Insights at Roche. So a real terrific set of folks joining us today to share their insights and what they're doing to innovate in the space. And I'm going to hand it over now to Abhinav to I think we're going to go first to Abhinav at Innovaccer to share a bit of what they're doing before we go into some discussion and interaction. And please share your ideas and ideas on the chat. We'll hopefully get to Q&A and even raise the issues we see on the chat as we go. Over to you.
Perfect. Thanks, Daniel. Firstly, really fantastic on what UCSF is sort of doing to push the ecosystem forward and really drive healthcare into its digital future. So super excited to be associated with you guys, and the event this year was great. Hoping that this basically just grows and we push healthcare into the future through our digital sort of ambitions. Hopefully sooner than basically everyone expects. So fantastic. Thanks for setting this up. At Innovaccer, just to sort of talk a little bit about what we are trying to do at Innovaccer, all of us basically have in the last 10 years have basically seen healthcare basically moving towards digitization to a certain extent, where we've seen electronic health records and a lot of technological themes basically being deployed by payers, providers, life sciences companies in general. So for the first time, I think we have an infrastructure where data is basically present around the patient. We have basically so much data that we've collected. Doctors have basically put in millions and billions of hours basically just making sure that we have the right kind of documentation and understanding of how health progressions have sort of happened for people. We have longitudinal patient records that are now existing with payers, and I think for the first time we also have science basically progressing much faster than education at life sciences companies. companies. So all of these themes are in some way sort of like coming together, where there is this huge explosion of data and information that has happened on the health of the patient. Our core thematic as a company is how, with this explosion that's starting to sort of like happen, how do you create like an underlying data platform that really brings in data from all of these sources, creates one unified patient view, and exposes it for further software innovation, whether that's basically digital health innovation, whether that's value-based care innovation, whether that's clinical insights at the point of care in general, or basically whether that's opening it up for startups to really go build basically like the next generation of digital health companies per se. So we've had like we've grown quite a bit. We are now basically like deployed at 50 plus like health systems across the country. We are now expanding fairly rapidly, like on creating this ubiquitous data standard on which basically like things can be built, whether that's like workflow innovation or whether that's basically like business model innovation on top of it. And we're very excited to sort of like see some of the impact that data can really have in care delivery in terms of improving outcomes as well as reducing cost structures per se. So again, super excited to be here, super grateful for you guys to be hosting this, and would love to kind of really like talk more about this as with our esteemed panelists today.
Thanks so much. Great intro and really tremendous unmet need and solutions that you're building. I think we're switching over next to Roche.
Wonderful. Thanks a lot. And again, really happy to be here as with the rest of the colleagues. Great topic to discuss. So, I think in ways of introduction, I think maybe this is one of the sort of the not well-known sort of efforts which is underway at Roche. Of course, community knows Roche as the, we have a long history of biotech innovations, both in terms of therapeutics and diagnostics, and those are the two big pillars of company strategy. But more and more, we believe, just like diagnostics and therapeutics, digital itself has a huge role to play in terms of elevating medical value. And some of it is direct in terms of the topics of digital therapeutics, which we talk about, but more importantly, even for being able to orchestrate medical value coming from diagnostics and coming from therapeutics into clinical workflows and patient journeys, digital has a significant role to play. So we want to be directly engaged in that. And so, that's where I sit in the organization, where we are looking to build a third pillar as we look to our future, which is really focused around leveraging clinical and data science to add intelligence to patient care journeys, whether it's decision support for patients or whether it's for clinicians overall. And we are focused on multiple disease areas. And we do believe that, our having been in the healthcare ecosystems and with a deep understanding of disease pathways and all, we have important contributions to make here. So, again, very exciting area for us, a lot of effort. You will stay tuned for a lot of things which will come from Roche as a digital solutions provider in the coming months and years. And looking forward to the conversation here.
And next, we are going to turn it over to Upstream.
Wonderful. Thanks so much. And Daniel, who's our moderator, and Abhinav, I couldn't agree with you more. My name's Sanjay Dadamani. I'm a clinical cardiologist. I'm the CEO at Upstream. And, we've now come to a point where there's been a decade of experience in payment models. There's been a decade of experience in value-based care as it relates to what the care model and the clinical model. But we continue to see a very recurrent theme, that of fragmentation, difficulties, burnout on the part of providers, the small minority of patients with medical complexity really having unmet needs and rising costs. And in that background, Upstream as a company, we have really harnessed our ability to scale clinical and pharmacotherapeutic care to, using the rubric of care coordination and care management for the benefit of the patient. But in terms of the scalability of that, we embed our clinical teams, especially leading with a pharmacist, into our partnered practices. This allows those team members in turn to deburden the physicians, really focus on clinical and care optimization and coordination of the patient, and allow physicians who would have otherwise been locked out of advanced payment models or full risk or full financial models to participate there really is a means, not just of profitability to the practice, because I truly believe primary care can be profitable and is not a subsidy on the healthcare system. But in terms of being an environment where we can clinically optimize patient care, reduce the burden on physicians, improve overall health outcomes, and therefore reduce costs on the national level. So our company focuses on that through the really judicious use of data, empowering our teams to identify patients who really meet the needs and have unmet needs and gaps in care, and then supports those patients by giving the clinical teams the right levels of information in order to close care gaps and clinically optimize care for patients.
Great, thanks, Sanjay. And now over to Ashok, who's the Chief Data Analytics Officer for Ant.
Thank you, Daniel. I'm really proud to be part of this esteemed panel. Abhinav, Sukhveer, Daniel, Sanjay. Great to see you guys. So at Anthem, we serve over 118 million, consumers, including 46.5 million, health plan members. So what that translates to is a lot of data. We have data for over 200 million members. Some of them have been ours in the past. And to Abhinav's point, it all starts with having a good foundation, and the way we are looking at it is focusing on whole person health and collecting data that's a combination of the administrative data set that we have, the claims data, et cetera, member eligibility, but also complementing that with the clinical, EMR, ADT data, that's where, partnership with, with Innovaccer or, similar type of focus, from a platform standpoint, but also a huge focus on, like Daniel, you mentioned the emerging data sets, genomics, device data, home health, and even the data through virtual digital therapeutic tools, et cetera, that's exploding. But also social drivers, huge emphasis there, both at the member level and zip code level, and behavioral health data, pharmacy, good to see the payer provider, pharma, life sciences interaction too, real world evidence, access to clinical trial matching, et cetera. So our focus is really combining these data sets, using the word like whole person health, longitudinal view, but really taking this data and turning it into precision insights, more accurate, timely gaps in care. And since, we have such a huge footprint of population and we don't own provider groups, our focus is collaborating, partnering, and pushing providers, and collaborating them into different types of innovative care models or value-based care payment models, and including, collaborative, risk arrangements, so we can really keep the consumer in the center of everything and improve access to care and reduce cost and improve quality. So data is in the center of everything, but it's really not about the data we have. It's about the outcomes through insights that we generate. So thank you.
Great, thank you. Thanks to you all. It's amazing to see, not new players essentially, but from payers to pharma really get into the data game. And now the challenge, of course, is to translate that to, as you mentioned, outcomes. So maybe I'd start with Abhinav at Innovaccer. Your key mission seems like to translate, data to actual insights to outcomes. What are some of the key challenges you see in especially entering the workflow of the clinician, whether it's a physician, pharmacist, physical therapist, nutritionist, to get those actions and outcomes to transform from the.
Yeah. So I think so we've been at it now, I think for 7 years. It's I think before we had the first like when we went and worked with, I think like our first customer, like we had like 250 engineers basically working on standardizing data sets to basically bring that onto like one common data model. Like it's data was basically very different in one Epic instance, and it was like different in another one, and the Cerner data set. And you thought like at least one EHR would be structured in a particular sort of like way, but oh my God, like the complexity of basically like data and how it was sort of how it's been like structured like very, very differently, like to really get like a longitudinal view of the patient and really create that coming from like I think like payer data, bringing like together clinical data set, and really creating like a long-term sort of like view on how health has basically like progressed for that patient is just like an incredibly hard thing to sort of like do. So I think like when we started, like it was just like very, very hard like to get like a lot of those things into like a particular structure where you can downstream really impact workflow. Right, because if you are basically like getting data from all of these sources and you put like something like downstream as a care gap, etc., you need to basically be like making sure that you're getting like all of those elements and putting that in a standardized like framework downstream. Because if the doctor on the other hand is not really getting like standardized like thematics, there is no force of habit that you sort of like end up creating, and then it basically feels like one other ping on the EHR, which did not sort of like end up like doing anything per se. So I think we worked like the first few years, we basically like worked like very, very deeply to sort of like just make sure that we write templates and connectors into like all of these things, and then create like this like longitudinal like data model on which like analytics can basically be done, and you could then basically like push those analytics and insights back into the point of care. And now basically I think like over the last few years, like the few thousand doctors that are sort of like using like our platform, what we're seeing is that when they basically like have these things at the point of care, they end up closing basically 31% like more care gaps than if you did not sort of like present, which basically means that the quality of care suddenly basically goes up like dramatically if you put the right kind of insights in front of the doc. That's what Sanjay was basically mentioning. That's what like I think like Sufir was saying, and Ashok was saying, that outcomes is what sort of like end up mattering, and like how do you basically get that right piece of information in front of the caregiver is just like an incredibly hard challenge to sort of like solve. And like fortunately or unfortunately, like I think like we've all sort of like spent tens of billions of dollars to basically like install EHRs, and everyone sort of like did their own version and data model of those things. So I think it is like an incredibly hard like thematic to really standardize these themes. But as we sort of like do that, I think the impact that you can sort of like create by just like making sure you put the right kind of things on the point of care, both in terms of like improving outcomes as well as reducing fatigue for the doc in general, is incredible. So I think we are very excited about the early results that we are seeing with like our customers and partners that we sort of like work with. But I would just say basically like we are very, very early in the journey of how pointed insights at the point of care can really drive like a very differentiated care model like going forward in the future. But like if we are able to sort of really do this, it's just going to be like incredibly game changing, and all of the things that we hear about like the fatigue from a doctor's perspective, etc., just go away. Like the way Google Maps tells us like turn right here, turn left there, and like if that kind of navigation, we all talk about patient navigation in some way, but the doctor's job is to basically like put together this like incredibly hard puzzle in a 15-minute period all the time. And if you could really provide the right kind of insights at that point of care over a period of time, it just like is going to be like an incredible like movement forward for the industry. So we're very excited, and like I think we are like probably like 5-7%, 10% like there in terms of like where we eventually need to be like from an industry perspective. But I think with our collaborations, I think with like Upstream, with Anthem, with Roche, like I think we're very excited about really being able to sort of like drive this like entire space forward.
Yeah, I love the example of Google Maps, right? You're taking multiple data streams, crowdsourcing them, and presenting them in a very easy to use interface that is always learning from others. And in your collaborations, what are still the barriers and the unmet needs that you need other collaborators to join you with, or pain points that you think you'd like to have a call to action to solve for?
I think from our standpoint, we feel like this is not something that anyone is going to solve alone. Like we've far too often basically felt that this is like one person's or one company's problem to sort of go solve. It's not going to be solved by any company. I don't think it's going to be solved by a payer. I don't think it's going to be solved by a provider. I definitely don't think it's going to be solved by a technology company, right? So how do we bring the power of deep research that life sciences is sort of doing, the deep actuarial and analytics works that payers are doing, and incredible basically modern day organizations Upstream on how do we sort of really change care delivery? How do we bring all of that together and then merge it in a user interface perspective, from a doc perspective, and from a patient perspective? I think that's basically going to be key. And so anyone, I would just say basically the spirit of collaboration, that we need to come together as an industry to be solving this, is what sort of needed. If we keep basically each one of us basically wanting to do everything, I don't think we are going to be really good at anything over a period of time. So that would sort of be my general sort of call to action on that.
Yeah, totally agree. It's a team sport. And you mentioned Upstream, and Sanjay, a question for you. I mean, you bring in other elements. The social determinants is obviously a hot topic, bringing in social workers, connecting the dots from, let's say, non-usual data forms. You don't usually see some of the social determinants in their medical record. What are some of the lessons and collaborations and pain points you see that are available today?
Great question. Before I answer that, I want to touch on something Abhinav said. This is not just about collaboration. I think this is a recognition of technology in the service of the right clinical operating model. For a long time, that's been disconnected. There's oodles of data. We sometimes don't even know what to do with it. The example I would choose is really fragmented pharmacotherapy. There are patients on too many drugs. There's overprescribing. In fact, we really need to have an active approach in the health delivery system on deprescribing in many instances. And then, of course, there's clinical optimization and pharmacotherapeutic optimization, in other words, patients where there's underprescribing going on. In some of the advanced payment models, and now to answer your question, there's a requirement, even now on a regulatory basis, is take, for example, ACO REACH, the evolution or rebooted direct contracting program out of CMMI. There's a requirement for health equity. Programs are going to have to come up with very successful health equity plans. And in order to address that, we do need data. We need data on social determinants of health. And there's, a very loosey-goosey term on social determinants of health, but it's actually recognizing and understanding and having a comprehensive approach to unmet needs of patients depending on different segments and different lenses. It's not just poverty, it's all kinds of risks and vulnerabilities that are present within a society. And some of those are solved outside of healthcare, some of those are solved within healthcare. And I think those are ones that we can have disparate sources of data from clinical, from claims, patterns and approaches. Our example is also very untechnology sophisticated. Example I give you is our pharmacist or nurse who's sitting there in an office in order to determine a fall risk isn't just, checking a box on, a few things that they're finding in the MR. They're also looking at the patient walking into the clinic and, how they even take time to stand up from a seated position. And it's incorporating that. And so I think we're going to get there. We're going to get more and more sophisticated, but I think we shouldn't lose our sight on the target.
Yeah. AI is easy, AV is hard. Targets are important and often aligning on what the right targets are. I think a big target for pharma, maybe pivoting over to Sukhveer at Roche, is understanding the patient journey and not just the API, the pharmaceutical in its own silo, but in the context of a patient's life and the caregivers and beyond. What what opportunities are you seeing unlocking within pharma and collaborations with others on the call to make that patient journey more integrated and to match the right?
Yeah, I think, Daniel, you hit the sort of the nail on its head in terms of the, I think the graph you showed up front about, I think that really summarizes the problem well. So I see there are two dimensions on which there's a lot of work has happened. One I would call knowledge or medical value. So there are new treatments coming into play. There is new guidelines. I mean, just the amount of sort of medical value to be deployed is increasing exponentially, right? And a lot of innovation has also happened on the context in which that medical value needs to be applied. That means patient data, patient journeys, that's expanding, right? So now we're talking of sensors, and we can bring social determinants of health. So which makes sense because most of patient journey lives outside the walls of the clinic. The problem, what we are seeing and where we want to see the opportunity is you have knowledge on one hand, and you have patient context on the other hand. Both are getting more complex. Now, how do you personalize this knowledge by applying it to that ever-expanding patient context? I think that's the problem where what we need to solve for. And I think, I love this idea which was mentioned about we need a new clinical operating model, right? So we need to orchestrate the flow of this value in this complex setup. So that's a big opportunity. But I think equally important it is to do it in a way where patient and clinician experience gets elevated, right? So that's, just presenting forms and more check marks and more things is not going to solve for that, right? That's often our response to some of these things. Oh, let's add another assessment, or let's add another form which somebody has to fill. That's not. So I think solving this problem of personalizing by sort of how to apply ever increasing knowledge to a specific patient context, that is personalization, but do personalization in a way which elevates experience and also doesn't compromise what I would call equitable access, right? So, that we should never lose focus of. So I think that's where we are. What would need to happen though, we can't, often what's happening is we are trying to solve this in our own silo. Somebody's building technology, someone else is, revising the operating model, someone else is doing the data layer and all that. I think almost a clinical operating model where in real world context, a clinical team and the technology company and sort of the medical value company and, and the data company, they're working together and learning from that experience and optimizing it, right? So having this learning system built off of these partners taking, shared risk, I think that's what is needed, because right now we are kind of building a Lego block sitting in our own households and trying to make them fit together in it's almost like building the plane while trying to fly it, which might be much harder to do. So that's why that's wherein lies the power of collaboration between different entities. Some of it is starting to happen, but I think there's a lot more to be done there. I think if you look at everybody in this room, this could be a great, all the right ingredients for building such an operating model.
Yeah, I love the idea of a new operating system for healthcare. And that often is driven by the incentives, and the incentives are often driven by the payer. So we're lucky to have Anthem here. And I was actually lucky to work with Anthem. We have built this XPRIZE pandemic and now Pandemic and Health Alliance task force, and the alliance is all around new collaborations, convergences to solve initially for the pandemic, testing, PPE, diagnostics, therapeutics, but also the bigger picture now across health. And that means we need all players. And Roche, and the folks at Anthem, I know have incredible depth, as mentioned on the data side, and can both engage the member, the individual, the patient, as well as the clinician. What are some of the elements that you've seen, best examples coming out of the new Anthem and Anthem AI that are moving the needle on taking Anthem's data and turning it into actionable insights and outcomes?
Yeah, absolutely, Daniel. So, before I get specific on the Anthem side, just want to highlight one of the key points that Sanjay made on health equity and payment models. Couldn't agree more. The big opportunity is, when we are looking at whole person health, we are mostly focused on, while healthcare is important, I think we also look at health, and in some cases when we use a category called provider. Primarily, it's clinical provider, whether it's the physician, but we also have somebody for our Medicaid patient who's building a ramp at the home as a provider of services, right? So when you're focusing on the whole health of a person rather than healthcare, like where they live, what they eat, transportation, and collecting data. We had all this data sitting in Access databases, in each of the state Medicaid, teams. Now we have, integrated that into a central, repository, so it can be made, actionable. And some of the, and examples that we have uncovered is, we have a big penetration in the Atlanta region, and in Buckhead, which is a suburb, average life expectancy 86 years old, if you pick, the center, but you go 3 miles out, the life expectancy drops to 64, right? So about the average cost to treat a diabetic for a 64 versus an 82-year-old, it's 30% higher for a 64-year-old in, 3 miles from Buckhead, right? So, and a lot of those factors are not because they're not clinically treated, and I think, Sanjay, you mentioned that, some of them are probably overprescribed. It's about, looking at all the other factors that would behavioral factors, loneliness factors, whether they have access to the right, digital equity aspects. So we are absolutely factoring that into the payment models to incentivize the physicians and the care teams and the other navigators and the community to make it happen, right? So that's really what we mean by whole person health. So coming back to answering your question, Dan, in terms of what's, when we started Anthem AI, the focus more was very much of we build this model, this is all about AI. Now we are really pivoting to, here is the outcomes, that we have generated, right? Leveraging the rich data sets we have, or even, the AI teams, whether it's in Palo Alto, Israel, or a vendor, partners, but primarily focused on here are the outcomes, whether in the outcomes can be improved, quality, that improves our stars rating, or improved, member satisfaction when they go to our, Sydney, tool on finding care. So that's really how, or even, how do we drive more providers to risk collaborative arrangements, or even improve, prior auth automation, or even reduce complaints from, providers on appealing on a prior auth, delay, so those are the key metrics. It's very much metric driven and focused on outcomes where, sometimes the model could be AI driven, sometimes it could be, really, automating, end-to-end processes, but more importantly, leveraging data, and learning from it. We have a framework, dial data, insights, actions, and learn, with hyper focus on learn, because we clearly know that we can get it right the first time, right? So it's that whole closed loop. So that's really how we are focused on. But I would say if you really don't have the right data, the right quality, and more importantly, the trust, right? Because when we have been working with almost every large provider in the country, the most important thing they say, if we ask them for access to medical records, is reduce our admin burden, right? Streamline claims payment, automate prior auth, or streamline prior auth, and don't come to us asking for medical records 5 different times through different vendors, really streamlining the whole payer provider. And that's really where interoperability, and streamlining, how we exchange data bidirectionally really comes into the mix. So that's where most of our focus is. And I know we are still early in the journey, but I do see, really big opportunities, with the players like this in this panel and broader to really make an impact.
Hey, Dan,
impact often. Go ahead.
With your permission, I'm going to provoke a question of Ashok, because I think what deeply resonates to me is 2 things. One, we don't know as a provider what we don't know, and the payer has a lot of the data, and we could potentially be incredible collaborators. And two, are we using that data for screening so I can identify a vulnerable population, or are we using it at the point of care for interventions? And I think for me, as I look at what we're doing with our Innovaccer data activation platform, it's really the single point of integration of the data at the point of care. And so the more I have at that single point of care, the more confidence my teams will have in terms of being able to quickly bring up something and actually during that moment of exchange, help in closing a gap or enabling a patient with particular resource or intervening even in the home like you mentioned. But I don't think there's enough of that collaboration going on. In fact, the more and more providers take on full risk or advancing risk, there's more inherent an expectation that, oh, they're going to handle it, they're going to do it without the need for our support. And I think it's actually the exact opposite. We need more of a collaboration. We need more support. We need more of information sharing in order to do a great job in a full risk environment.
Yeah, couldn't agree more, Sanjay. So the conversation should be, like when we say we have great insights, which is why when I mentioned term outcomes, if the same insights are not at the point of care or integrated into the provider workflow, then it doesn't matter of all the insights we have, because the impact or the member reach or giving that to the physician at the point of care or the care manager, if that is not enabled, so that's really, and really the payer provider or the ecosystem partnerships, our discussion should be not centered around why do we have, so many AR issues on payment side or, prior auth grievance and appeals. It should be more focused on like what you mentioned on, better collaboration, keeping the member at the center of everything and more seamless data exchange, so we can serve the member irrespective of where they get the care. It could be at home, it could be through a digital tool, it could be in person, or it could be in any of the ambulatory care settings, right? So
we have some catching up to do.
Yeah.
Both as an industry and personally.
Well, one thing that both of you guys mentioned, we talked a lot about data and new sources, and also was raised about the idea of trust and also the need to translate data to insights. One of my favorite cartoons from my exponential medicine conference is a cartoon of a doctor, listening to a patient and looking at him saying, just as I thought, you're generating too much data. Where are we? Maybe Innovaccer can address this. Where many clinicians do not want more data. They don't want my wearable data, all my real-time, proteomics or microbiome data. If I generate that, where are we with the ability to now make sense of that, synthesize it? Obviously, AI machine learning is here, but sometimes the algorithms behind them aren't always understood or clear to translate. How do we go from data to insights that are trusted and the user interface to make those utilized at the point of care, even when the data is made available?
I think there is so much progress that we are sort of like making in general. I think for a really long period of time, almost everyone has just basically focused on basically the quality and care gaps that have been defined by Medicare, because that's where I think where the money flows, right? I think that's how Medicare is basically defined. You would sort of get paid, everyone sort of just focuses I think on that, and basically risk prediction models in general. So I think the actuarial work that's basically required from a health economics perspective on how could you basically really drive better basically care, and how can you basically make it easier for the patient, how could you sort of drive that. We are now starting to see a lot of that happen in our patient interaction applications, when we've sort of for the first time opened up this information to patients, and where they are sort of interacting with endpoint apps and seeing basically things. We are now really understanding that, yes, I think they're interested about the care gaps that Medicare sort of defines in some cases, but in most cases it's very different sort of thematics. How do I basically reduce weight is basically something that a diabetic patient basically clicked on 67% of the times that we sort of send out that message and educational sort of content in general, right? And if there is basically a series of educational thematics thereafter, and a dietitian that we could sort of put on it, overall, basically, like the health outcome is basically changing in like very, very sort of like dramatic ways. I think like we are now like for the first time, because you are creating like liquidity of information, you are now going to start seeing learning on top of it. Like people talk about like AI and machine learning in like so many different ways. Like it's generally in all cases, like unless you have the data infrastructure to really power a lot of those things up, it generally sort of doesn't end up like giving out any meaningful insight. Like it's garbage in, garbage out in most cases. Like so I think like as we are now starting to see basically that like for the first time, I think in value-based care economics, where like everyone is incentivized to really keep the patient healthy and really keep the cost structure sort of like down, you're now starting to see people wanting to really like care for the patient, not just on like a few particular metrics, but how do we sort of like keep them healthy, because everyone like from top to bottom is making more money in general if the patient is healthy, not when you are treating them when they're sick. So I think this entire transformation like that's sort of like happening around healthcare being delivered to like health being taken care of is like the massive transformation that hopefully value-based care is starting to sort of like bring in. Sanjay talked about it, like medications and all of those things. We heard, I think, like the same thing from like Anthem from and like a lot of the work that we are sort of like doing with Roche is basically like around like some of these areas as well. Pick up disease areas and don't think of them as one intervention. Think of them as continuum, and how do you basically really solve for that continuum really, really well, and what are interaction points that you could sort of then like solve for, and like to the point where this is the first time like probably for in ever where we are seeing some amount of data liquidity happen, and therefore like I think the algorithms and the ML AI pieces have a lot of catching up to do like on that front, but I think we're making incredible progress on that front as well.
No, thanks, Abhinav. I mean, I think, Daniel, that's sort of, it goes to the heart of like kind of the thesis of our collaboration, right? So we want to focus on creating signal from noise. And I think that's what you were speaking to. There's a lot of noise, and then the noise is increasing, sensors and all that. So how do you convert all that into sort of meaningful and actionable signals? And I'll just take simple example, for example, I use this Whoop. It's one thing for me to look at my body temperature and heart rate variability and 6 different factors, but turning that into one score, which tells me whether I recovered well, yesterday or not. And I think so. It's a very consumer-centric example, but I think a lot of that needs to happen in the deep clinical settings also, and that's where we are focusing in oncology, infection management, and everything else. That how do we turn, first of all, solve the problem that you have the longitudinal view of the patient journey, but then how do you convert that into actual actionable insight, right? And a lot of work needs to happen there, but that's where a lot of our collaboration is focusing, because that requires deep clinical science. It requires medical evidence generation. Is it meaningful? Does it really change course of the treatment or follow up or treatment response assessment and things like that? So it's again, we are very early in that space, because so far we couldn't even start doing it, but at least now we have basic foundation into which we can start adding depth, which is specific in terms of clinical outcomes.
Yeah, we're moving from that usual intermittent data in the 4 walls of the clinic to the continuous data from your Whoop or your Oura Ring, your Apple Watch. I think an interesting example now is that the Oura Ring, a study with UCSF actually showed that you could tell what someone's titer was going to be after a COVID booster based on changes in heart rate variability, respiratory rate, temperature, and others. So that flows into many drugs and other realms. That sort of is a continuous form of Internet of Things, Internet of Home, that will sort of inform the data sets over a continuous basis. And companies like Verily doing the Baseline project to have sort of new forms of digital biomarkers for health and disease. Any of you have any favorite new forms of data and insights that are emerging, and where collaborations need to form to make those useful?
I think most of them come around is the role of the digital and biomarkers, and turning them into sort of panels, whether they are diagnostic panels, treatment response assessment panels. Like if you look at, for example, neuro space, the neurodegenerative space, we often speak to companies, each one of them is working on a specific signal. Somebody is looking at sort of, ocular signals to determine dementia. Somebody's looking at voice-based signals, based on how your voice is changing. Somebody's looking at your total movement and all that. Now imagine as a clinician, if like 7 of these companies came to you with all of their signals and said, okay, we are useful in some way. I think where a lot of innovation needs to happen is combine these signals into almost like a diagnostic or a disease progression panel, which tells you that whether the disease is getting worse, better, stable. I think that's what really matters, right? So again, as going back to the initial point, that innovation on increasing number of signals is actually happening. We have a lot of those, but now next frontier needs to be, how do we integrate that information to provide actionable insight? But we are very excited as a company about sort of the signals being generated outside the typical care settings, right? So in between appointments, especially for chronic disease management and all that, if you look at it's not taking away the role of those physician-patient interactions, but making those interactions more meaningful, more insightful. What has happened in last 3 months, rather than relying on recency bias of patients, where they're really speaking to last 48 hours rather than the last 3 months. So how can we use that information? I think that's the most exciting area for us in terms of what we are looking at.
And Sanjay or Ashok, have you seen examples now where you can push the data back to the member, to the patient, to change their care journey and not just be part of the electronic medical record, but the personal health record?
Ashok, you want to go first, or?
Yeah, absolutely. Yes. Two, or at least 2 paths. One is we have a mobile app, Sydney, that has 20 million, registered users. So a huge adoption, at least from a registration standpoint. And so we are leveraging, so any information that we share to our care manager or to the provider, we have medication adherence related, drug, because when you have the longitudinal view, any screening, opportunities, like that we send alerts. But the key in all this is, when it comes to a payer, it all boils down to the trust. The trust is always between the member and the provider. So how do we, have that 3-way partnership, between the payer, provider, and the member, and where we can help is, as members go to different, providers, they could go to a gastroenterologist, setting, that's not connected to a inpatient stay they have, or to an orthopedics, So our focus is, how do we bridge the data? How do we build the trust? How do we share this information? But it's always in partnership with the provider, right? So that's going to be, and, depending on the more vulnerable population, helping our care managers or, community resources, with the right information. So we are really looking at it from a holistic view. Right, if we try to do it alone, I don't think, it can create that impact. So, Sanjay, please go ahead.
Yeah, no, I completely agree. I was just drawn back actually to an analogy while Sukhbir was talking around something I remember Roche was doing, which was looking at pro-BNP levels in the area of heart failure. And to me, that serves as an opportunity to, identify patients before they have clinical manifestations, for you then to determine how to clinically intervene. And if you think about, these 4 key levers we have the opportunity to drive revenue. We have the opportunity to raise quality or impact quality. We have the opportunity to improve overall health outcomes, reduce hospitalizations, or any number of, measures that you want to take that actually improves the overall, not just quality, but quality of life of patients and health outcomes. And then finally, total cost of care. And so the more we can identify patients early, intervene, we can also do several steps. And I think this is where data can help us. Which segment of that group are more eligible or more, able or capable of ultimately driving self-care. In other words, we set the ball in motion, but they can ultimately take better care of themselves. And how can the payer participate or collaborate in that process with us? Because we are under tremendous pressure with limited resources, especially in the provider space. And it's literally like the perpetual hamster wheel. So the more we can get patients early identified, care engaged, coordinated, and then a portion of them who are not permanently either disabled or dependent, out into a self-care algorithm that can help, themselves be supported, I think it's a win for everyone. It's a win for the payers, providers, and most of all, the patients.
Yeah, and I think different patients have different needs and different ways to align incentives, and depending on age, cultural language, and beyond, we need to sort of make it more approachable for patients to own their own data and to share it. I think on the chat, I made a point that we're still early in the value-based care cycle. We've only got about 5 minutes left, so I thought we maybe use the last few minutes to also answer some questions, but also from each of you to share, let's say, your 5 or 10 year view. There's that famous quote from Bill Gates: we overestimate what happened in the next couple of years and underestimate what might happen in a decade. So maybe what might be putting on your futures hats, what might be where you see things heading, particularly if we can leverage these collaborations, on this call, and others to sort of move to where we might want to be in the next decade. And maybe we'll start with Abhinav and go around and then close. So quick 5-10 year view.
I think in a 10-year view, I think most of the data that's basically being generated is not like hand type data, for sure. I think more and more is basically getting generated through devices. It's basically patient generated information, and our ability to sort of really merge that with already longitudinal sort of information is really going to drive care into a very, very different paradigm. I think it's not care basically within the four walls of hospital is basically how it's basically being delivered today. I think over the next 10-year period, care delivery is basically going to change on its head. What doctors basically end up doing, what nursing staff is basically doing, and what patients are basically doing from a self-care perspective, that's basically going to change fairly dramatically. And I think the role of AI and intelligence basically in really driving care more meaningfully on our mobile phones, on basically our VR devices, is basically going to become incredibly real over the next multiple years. I think a starting point of that, in the next couple of years, is just making sure that we get I think cloud connectivity and data connectivity up and running into basically all of these different settings of care. Once you sort of have a little bit of that connectivity and data standardization basically up and running, you will be very quickly sort of we're basically at that point where we are still mapping the streets, but once that's all basically surfaced up, you are then basically going to see Google Maps sort of end up appearing. So I'm super excited about where we are basically going to be from a healthcare delivery perspective over the next 5-10 years. It's hard, it's painful, and I think it's basically taken sort of a ton of time, but nothing ever worth doing was basically easy either.
Exactly. Sukhveer, over to you.
Yeah, just quickly, I think going back to your original theme, I really think quite a few new operating models for delivering care will emerge. We will see unique partnerships, which we haven't seen in the past in terms of technology companies, clinical networks, and the risk-bearing entity. So the whole value chain will get rearranged. We are seeing some of that in certain pockets. And I really think when we often talk of how do we shift the cost curve to the left, that is diagnose early, prevent early, do interventions early, I think we will start seeing real change in that area. We will see real outcomes in that area in 10 years. So far, I feel like sometimes we're just squeezing the balloon, changes, the air just shifts somewhere else. I think once we have those new operating models, we will see that real impact of those changes.
Perfect. Sanjay.
Yeah, no, I'm very optimistic. I know we're going to get there. We've had tremendous experiences that mentioned over the past decade. In this decade, as we look ahead, we're all trying to focus on bits and pieces of this. We are certainly at Upstream focused on a total cost of care environment. And the reason is that we can then reallocate the dollars. And I think that solves for a whole host of things that, we otherwise, have to factor paying for, which we could, go upstream to, to solve. The other part to this is, right now it's very delineated. You have payers, you have providers, you have patients. I think ultimately, as we go beyond the lip service of patients being at the centers, we will all ultimately become patient providers, I think.
Perfect. And over to Shop, and we'll Premier for Shop. There's a question in the chat from Priyesh Gupta about your business models, because often the payers might win by doing better prevention, but what happens to the incentivizing the clinicians to be rewarded for moving to the left and keeping people healthier and rewarding that kind of outcome, not just the sick?
Yeah. No, absolutely. One thing I'm very, I agree with Sanjay. The future is definitely bright. But I would say, we would talk less about claims, and claims will be more an afterthought. It'll be more towards, 100. I agree with Sanjay. The future is definitely bright, and claims will be more than our provider talked about. I think that the whole person, and the focus is the whole person. Emerging data, devices, etc. The care models will really be
I think we've lost Ashok's
what is
audio.
convenient for them, from a payer, from an anthemization, lesson. So anyway, hopefully you guys can hear me. So
we lost a little bit of that, but yeah, new care models, new incentives, and hopefully all ships will rise. So we're at the end of our time. This has been a great conversation. I want to thank leaders from Innovaccer, Anthem, Upstream, and Roche for joining us today. As I'm an optimist, I think we're all here because we want to move the needle in healthcare, and that new oil data is not alone sufficient. It needs to obviously translate to insights at the bedside, the website, clinical trials, pharma, and beyond. It takes new collaborations, mindsets to take us to where we can be in a decade, whether we're optimists or not. It's about collaborating, cross-fertilizing, and thinking about how we can do things both differently, but learn from the past and move things forward. So thanks all for joining today, and let's keep collaborating to build a better future for health and medicine for all of us. And of course, thanks to UCSF Health Hub for bringing us all together today.
Thank you guys so much for joining us. Loved hearing this discussion. We will post a recap reel online and also be emailed out to all of our participants. Again, thank you so much. It was great hearing from all of your wonderful insights.